Well, hi everyone. Today I'd like to talk with those of you who might be brand new nurse practitioners. Because after decades of practice, I have some hot tips that I think will help you and that I'll share. First of all, congratulations, because becoming a nurse practitioner is not a small thing. You've completed a lot of demanding coursework, clinical hours, exams, papers, case presentations, and you were probably doing all of this while you were working, maybe even full time. And now suddenly you're stepping into a role where people are expecting you to diagnose, prescribe, document, educate, make decisions, and many times do all of that very quickly. So it's very exciting, but it can also be very overwhelming. In my first year as an NP, back in the very early 80s, I carried around a suitcase full of reference texts and protocols. Because we didn't have smartphones back then. And there was no legal cover for anything that I did in this role. In fact, I had a lawyer who used to always say to me, be very careful, because otherwise you'll end up as a test case. But thankfully, things are so much better now. And I want to share some of the things that helped me through those first few years of advanced practice. So, the very first tip I have is to bring the one thing that most medical practices are missing. Now, this first hot tip comes directly from my clinical education. I was very fortunate to be at the University of Rochester, where Loretta Ford was dean. I imagine you all know who she was, right? She's considered the founding mother of the nurse practitioner movement. What I learned under her leadership really helped to shape my practice from the moment I had my very first job. And what was that? It was that our nursing foundation is one of the greatest clinical strengths an NP can bring into a practice. Whether it's a private office or a clinical setting or a specialty office or a primary care setting, in every one of those settings, a nursing presence can make a big difference. Because for new NPs, it can be really tempting to focus exclusively on diagnosis, prescribing, documentation, productivity, and keeping up with the schedule. And yeah, that all matters to a point. But, we bring more than diagnostic and prescribing skills into that exam room. We bring nursing. We bring listening, noticing, teaching, comforting, and understanding the person within the context and the culture of their specific life. That's a very different model than what medicine offers. I remember one situation in a family planning clinic where I was working during my early years. And there we had an intake person who first saw the patient. Then the patient was sent to me for the clinical exam. And then they saw an outtake person for instructions. So it was a solid structure. And it allowed us to see sometimes 40 or more patients a day. And one day, I saw a woman in her 40s who was there for a post-abortion check. Now, I had done many of these post-AB checks, but there was something different about this woman that made me want to say, "You look like you need to cry." And of course, she did. We spent a little time. Actually, it wasn't that much time, maybe about 10 minutes. So she could express and have her feelings validated. And for that, she was very, very grateful. Later, the manager asked me to please be careful what I said to patients, even though as a nurse herself, she recognized how valuable that moment had been for this patient. But that experience stayed with me. It reminded me that efficient systems do matter, but so does the human moment. And over the years, and with the changing legal status of nurse practitioners, I eventually was able to shape my own clinical practice in a way that more fully incorporated nursing. And if you have that opportunity, I hope you will use it. Because listening and presence, respect and true caring are not extra things. They're incredibly important for healing. So don't put your nursing identity on a shelf. Bring it into the exam room with you. Okay, the second tip is to leave a little room for doubt in every diagnosis. Well, now you do need to make decisions. And of course, you can't be paralyzed by uncertainty. But sometimes being too certain can become dangerous. Sometimes when we're in a new role, we feel pressure to prove that we know what we're doing, right? When I was a new NP, there was a lot of that pressure. Because remember, few physicians even knew very much about us back then. We wanted to appear competent. We wanted to sound confident. And we wanted the patient, the physician, and the staff, and maybe even ourselves, to believe that we belonged in this role. But when we jump too quickly to a diagnosis, some things can be missed. So take a brief pause. Ask yourself, what else could this be? That's one of my top 2 important questions. And another way to say it would be, is there something in this patient's story that I might be overlooking? And then the second question, bring the patient into your clinical reasoning by asking, what do you think this is? Over decades of practice, I found these 2 questions to be critically important. Adding to that, you could also ask the patient, is there something you're worried about that I might be missing? Questions like these can open doors. When you invite the patient into the diagnostic process, you communicate that you value the knowledge that person brings about her body. And that person has a lot of knowledge about their body. Decades of practice taught me that patients often hold pieces of the puzzle that don't show up in the chart. They may not use our language, but they often know when something feels different, strange, frightening, or wrong. I have seen so many women with breast cancer over the years who told me, I always had a feeling that something was wrong. But when I went and had a physical exam, I was told there was nothing to worry about. So the key point here, Invite patients into the diagnostic process. I know this is not typical of medicine, but here's where nursing can make that difference. And then listen very carefully to what they tell you, because it can make all the difference. Okay, tip number 3. Remember that guidelines are only meant to guide. Guidelines are useful. Algorithms are useful. Clinical pathways are useful. They help us organize our thinking and support evidence-based practice. But they're not a substitute for clinical judgment. The person sitting in front of you may not fit neatly into a guideline. I have found that that's more often the case than not. They could have multiple conditions. They may have unusual symptoms. They might have cultural beliefs, fears, maybe even past trauma. They could have limited resources or family situations that affect what care is actually possible. Years ago, again early in my career, I started a clinic for middle-aged women who fell through the cracks in Minnesota's healthcare plan for the uninsured. The program covered women with families and the elderly, but somehow many middle-aged women were left without the medical care and support they needed. I remember one woman who had very high blood pressure, off the charts blood pressure. She also had an inconsistent income. Some months she could afford the medication she needed, and other months she couldn't. So I had a choice. I could give her another prescription, carefully following the guidelines, and send her on her way. Or I could look more closely at what was really driving the problem. Her hypertension was not only about blood pressure. It was also tied to the stress of unstable income, depression, and weight gain. So during a brief follow-up visit, I sat with her in the exam room and we took a few minutes to look through job ads together. We talked about what might be realistic for her. Now, I know that does not sound like a traditional clinical intervention, but it mattered. Over time, that support helped her establish herself in a full-time position. It helped her manage her hypertension, improve her depression, and begin to get a handle on her weight. That experience reminded me that the plan has to make sense for a person's real life. And that's what will ultimately determine whether there's a positive outcome or not. So, use guidelines to guide you. Human beings can't be reduced to a test tube. We're really not all the same. Recognize this and keep thinking. In this scenario, it was a very out-of-the-box thinking that made the difference. So don't feel compelled to practice only through the lens of the medical model. NPs are not physician assistants or junior doctors. They are advanced practice nurses who bring additional perspective and management strategies to complement the medical care that they can provide. This can add true value to a primary care or specialty practice, and believe me, it will be recognized. That's where nursing practice and medicine can come together beautifully. Okay, tip number 4. Pay attention. Patients notice more than we think. So, my doctoral research aimed to understand the experiences of older women in primary care settings. These women taught me so many valuable things about the culture of primary health care. They notice whether we sit down and tell me that standing over a patient says, "I'm an authority over you." They notice whether we look at the screen the whole time. It tells them that what's on that screen is more important than what they're saying. They notice whether we seem rushed, distracted, irritated, or truly present. They notice whether we call them by name, whether we explain things clearly, and whether we seem to respect their questions. How we express the authority we have is going to make a big difference. Are we creating connections or are we creating distance? Are we sitting behind a grand desk when talking with a patient who's on the other side? Are we using our knowledge to reassure and guide, or are we using it in a way that shuts the person down? Now, this doesn't mean that we blur the boundaries. They're important. Or it doesn't mean we stop being professional. It simply means we remember that the way we speak, how we sit, how we listen, and how we respond can affect whether the patient feels safe to tell us what we need to know. And remember, well, let's see. There is one story I can share first. It's a little humorous. I remember one older woman who complained of urinary incontinence. She shared this funny encounter she had with a urologist. He told her to make sure she completely emptied her bladder every time she went to void. Her response to him: "Why would I want to hold on to it?" So his response to this woman communicated more than he probably realized. Older adults are sometimes, and actually quite often, spoken to as if they're children. She knew and felt that message. So try and remember, the difference between a superficial visit and a meaningful clinical encounter is our presence and the words we choose. Okay, the last hot tip. Once you think you know everything, it will all change. Human beings are complicated. No clinician knows everything, and the science is constantly changing. I can talk for days about all the things I knew about women's health in my first few years of practice that later all changed. In my very first year, I saw a middle-aged woman who complained of vaginal discharge. Seems pretty straightforward. She had an IUD in place, just a little bit of pelvic tenderness. So I consulted with my physician, and he advised me to remove it and start her on antibiotics. I did as he instructed and removed a Dalcon shield. Within days, this woman was in the ER. She had respiratory distress syndrome, and ultimately she needed to have her uterus and ovaries removed. At the time, we didn't know how dangerous this particular IUD was. And that's just one example of so many things we thought we knew and understood, from thalidomide to hormone therapies. So in order to be a safe and effective nurse practitioner, you need to constantly learn. It's not enough to go to a conference once a year. The key, I find, is to stay curious. If something doesn't seem right or it looks unusual, dive into the literature. If you're wondering whether there's an effective alternative treatment, follow your instinct and look at the research. Listen to your gut. But please, don't just ask AI. I use AI a lot, but not for these kinds of things. And I can tell you, it will always cheer you on, and it will give you very old references if you ask. So don't ask AI. You do not need to pretend to know everything. The docs you work with, trust me, don't know everything. In fact, the old adage is true. The more you know, the more you realize how much you don't know. That's a real sign of experience and wisdom. And that's okay. I've been practicing again for decades, and I frequently learn things that I didn't know. It makes it interesting and exciting. So ask questions. Get consultations when needed. Look things up. Read. Reflect. And above all, listen to your patients. They're going to teach you a great deal. You know, humility is not a weakness. It's part of safe practice. The new NP who asks a thoughtful question is so much safer than the new NP who pretends to be certain when they're not. Over time, your confidence will grow, but let it grow from real experience, from humility, and not from performance. So, to every new nurse practitioner listening today, remember this. You're stepping into a role with more responsibility, but you're not stepping away from nursing. Bring nursing with you. Bring your listening, your curiosity, your clinical judgment, your compassion, and your humility. And give yourself room and time to continually grow. This is Nonna Nurse, bringing you a little of my warmth and wisdom, and a reminder that you don't have to figure it out all at once or even alone. For more support, resources, and reflections, come and visit me at nursingprofessor.com.